So, good morning, everyone. And the study that we have done is basically nothing new in it. We all know that thin fat diabetes Indian phenotype, and it's almost about this. But we actually could separate it from routine of our type 2 diabetic patient from this novelty study. This novelty study was not basically idea to get separately such kind of subgroup. Even I am thinking of one another group, subset of group named LIRD, that is lean insulin resistant diabetes. It has also nothing to do with this novelty study, but we are working on the LIRD apart from different clusters of type 2 diabetes. So this is related to this only. So unmasking hidden abdominal obesity in type 2 diabetes mellitus and subgroup analysis from novelty study. Basically, before that, I would like to declare that this study was funded by a Cipla company, and conflict of interest could be SKRIAS are employees of Cipla Limited. All other authors have no conflict of interest. So BMI alone fails to capture abdominal adiposity, and we all know that we are thin fat Indian, and even BMI is not only less than 25, but in many patients we have seen less than 23, and they have abdominal obesity as well as they have fat deposition over vital organs. So particularly in South Asian population with lean phenotype and high visceral fat, where waist circumference and weight to height ratio are additional markers of central obesity or adiposity, and cardiac metabolic risk factors or risk, particularly in Indian patients with type 2 diabetes mellitus, are always high. So objective of this novelty study was not to get separate subgroup of obesity group in low BMI, but this was subgroup analysis of novelty study, and where it was assessed the prevalence of hidden abdominal obesity using waist circumference and waist to height ratio among Indian patients with type 2 diabetes mellitus where BMI is less than 25. So in this novelty study, it was a prospective study where multicentric observational study in Indian involving type 2 diabetes, where patients were uncontrolled with metformin alone, monotherapy, where HbA1c is more than 7%, but higher cutoff was not there. Vildagliptin specifically used in this novelty study, and that is 100 milligram extended release once daily, with primary endpoint being change in HbA1c over 3 months. So in the present analysis, patients with baseline BMI less than 25 specifically were identified, and prevalence of abdominal obesity was assessed in this group with waist circumference cutoff more than 90 centimeters in males and more than 80 centimeters in females, and waist to height ratio was more than or equal to 0.5 for both sexes. So result we founded of total enrolled patients, which was number around 1671. Out of that, around 30% of patients, so around 500 patients had BMI less than 25 among 1600 patients, and 1177, so it is approximately 70% patient had BMI more than 25, more than 25. So among BMI less than 25, so this is subgroup analysis of BMI less than 25, and what we found that in that 492 patient had waist circumference data, which was 281. So out of 492 patient had waist circumference data, and of them 57% had abdominal obesity categorized by waist circumference. 370 patients, so around 75% of the patients had waist to height ratio which was higher. but both the things commonly was seen in 270 patients, which was around again 55%. So approximately 55 to 75% of the patients had abdominal obesity in less than 25 BMI. So hidden abdominal obesity among patients with BMI, which was around 55 to 75%, based on maybe waist circumference, maybe on waist to height ratio, or both things common. So relying on BMI alone for obesity screening misses a large part of population with abdominal obesity. This is why our Indian cutoffs are a little different than Caucasian population, and this is why BMI less than 23, it is considered as obese patient or overweight patient in our Indian subset. So waist circumference or waist to height ratio can help identify 55 to 75% of individuals abdominal obesity who would otherwise be missed using BMI alone. So this is why we should not consider only BMI in our Indian patients. So waist circumference and waist to height ratio independently detect abdominal obesity and together improve identification in type 2 diabetic patients with non-obese BMI. Even like for an example, for me, I have BMI of 24.5 right now, and still I have grade 1 fatty liver. So it is so common in our Indian patients. Even though I do regular exercise, I follow diet strictly, I do intermittent fasting irregularly, but still I have grade 1 fatty liver. So it is so common in our patients. So using BMI in combination with waist circumference and waist to height ratio allows identification of large number of individuals with obesity, ensuring more comprehensive screening. And over half of these individuals showed a central adiposity based on either measure waist circumference and waist to height ratio, highlighting the need to include these parameters in routine assessment to avoid underdiagnosing of metabolic risk. So this is why don't rely only on BMI, and if you have a chance to use body composition analysis machine, please use it regularly in all of your patients. With this, I'll conclude. Thank you very much.